Our next speaker is David Hilliard. So Dave comes from a medical background. He got his MD at Columbia, did a postdoc in genetics with John Roth immediately after that. Today he's a specialist in the new molecular technologies that are impacting medicine in very, very important ways. So the practice of medicine has changed enormously in the last few years, where molecular biology and molecular genetics have been applied to various medical problems. David has really been at the forefront of learning all of those technologies and developing new tests for various types of diseases. So what he'd like to do today is, instead of presenting a general overview of all molecular technology, he's going to concentrate on one disease, one that's very important, of course, for the Philippines. Who today is Professor of Pathology and head of the Molecular Diagnostics Lab at the University of Utah, is going to tell us the impact of molecular technologies on hepatitis virus infection. David.
Well, thank you very much, Tim, and thanks Giselle and the other organizers of the symposium. Like Mike, this is my trip to the Philippines, and coming here is just wonderful. Scientifically, culturally, traveling food, I must say, and we've experienced that again as well on this trip. It's really fantastic. So I am going to switch gears a bit, talk about infectious disease, and I'm going to also talk a little more in the translational mode, less in the discovery mode or research mode for molecular infectious disease, but talk about how molecular technologies and molecular technologies very broadly, there are DNA, RNA technologies, sequencing technologies, but mass spec technologies and beyond. And we're in a physics building. I think one of the things that we're seeing very, very rapidly is basic principles of physics and engineering to next generation tests. I'd like to talk a little bit using hepatitis C as an example of how that can really make a huge difference. For any microbiologist who may be here, and I think the general audience realizes that microbiology, virology very much is making a match between a body compartment and present or absent in that compartment. We ask, is there herpes virus in the spinal fluid? Well, it's not supposed to be there. Is there enterovirus in the spinal fluid? Is there human papillomavirus for an extended period of time on the cervix? All of these plus-minus answers that molecular testing is so good at giving us an answer to have been during the last 10 years. With hepatitis C, it kind of covers the spectrum of what molecular testing can do. But what I'd like you to go back with an appreciation for is on just detecting whether it's there or not, and quantifying how much of it is there, in this case, in plasma. What molecular testing has done has allowed us to create algorithms as these tests become cheaper and not rate limiting in terms of how it is to make the test or how expensive it is to perform the test, but algorithms that allow us to wisely use what is really expensive and difficult to create, and that is drugs. So in the case of hepatitis C, we have, it's just like CONUS data. We've gone from one drug to 2 drugs, and we're very quickly going to 4 or 5 drugs. And drugs of great efficacy. And other technologies that's already shown is that using them, we can manage and ration and appropriately use these very, very expensive drugs. So, just very, very quickly, the obligatory slides about how important hepatitis is. In the US, we have about 3.8 million chronically infected individuals, but worldwide, it's just huge. So you see this figure that's a little bit dated, about 250,000 individuals. It compared to malaria and even hepatitis B, but it's a very, very significant chronic illness. And in fact, Hep C and Hep B are very, very concentrated and endemic in Asia and in the Philippines. So I think it's appropriate to talk about the impact of molecular technologies on the discovery of this virus. Because when I was in training, hepatitis A had been discovered and described. Hepatitis B, the Dane particle had been, the genome was quickly identified and sequenced and characterized. But we had an entity called non-B hepatitis. And in fact, non-A, non-B hepatitis in the States and Europe accounted for about 85% of blood-borne transfusions. So you very innocent procedure, pregnancy, appendectomy, tonsillectomy, and you needed a unit of blood. In the 60s, 70s, and 80s, you were tremendously at risk for potentially or actually fatal infectious disease in the form of chronic hepatitis, non-A, non-B hepatitis. At the time, we didn't know whether this entity, while assumed the evidence was very powerful that it was it a DNA virus? Was it an RNA virus? The course that was taken was to, through a lot of work, establish that this could be transmitted to chimpanzees and from chimpanzee to chimpanzee. Within chimpanzees, we could take a very, very large, concentrate in a fraction where viruses would go, a sample, and then I must say that it's a real synergism in this symposium. Sitting right here in your next speaker, Ron Davis, the inventor of the technology that led to hepatitis C, and that is bacteriophage lambda GT11 expression cloning. So what was to make clones out in lambda GT11 of this material that might contain to clone it in a way that would grab an RNA virus or grab a DNA virus. There were no restrictions to know which one it would be. And then to take a patient who had non-A, non-B chronic hepatitis and to use antibodies to screen these lambda GT11 clones. This clone's lit up. As soon as you light up a clone, you get a little bit of sequence. You quickly a lot of sequence. You see what viruses it's related to. It's a flavivirus. And Harvey Alter, in a 1991 article in the Annals of Internal Medicine, said, it's not unrealistic to expect that other elusive agents may now be recognized using similar technologies. And what an understatement this is. If you just look at testing, Boca viruses and coronaviruses were discovered this way, that if there's a pediatrician in the office, the human metapneumovirus, equally significant to respiratory syncytial virus, a cause of tremendous mortality in infants. It was taking old samples and then screening them looking for a new virus. It's really been fantastic, beyond just the work that was done in hepatitis C. Hepatitis C is different than A and B, and it causes chronic infection in about 85% of cases. So if you or I to have a needle stick or be transfused with an unstable, we would have about a 15% chance of actually spontaneously recovering from that infection. Most often, we would become chronically infected, and this infection would persist for years and years of our lives in the absence of any therapy. What's important is that the longer this chronic infection percolates, it begins to, in interaction with the immune system, cause inflammation and eventually cirrhosis of the liver. So 20 to 80% of it over a decade or two will become cirrhotic. And then in the setting of a couple of decades of cirrhosis, chances are about 1 to 3% per year that you will develop a very, very serious hepatocellular carcinoma. As you look in Asia, where the burden of hepatitis B and hepatitis C creates this perfect storm, in fact, beyond one or two other cancers, this is the most common lethal cancer that is seen in these societies. Just a tremendous importance worldwide. The chronic and latency latencycy see between the initial infection and the development of cirrhosis or hepatocellular carcinoma illustrated in this study from Austria, where you can see that the initial infection in a cohort of patients, these patients go on completely normal. If they go in, maybe they'll have a liver function test that's a little bit abnormal, but they feel fine. They think that everything is fine. Eventually, their liver begins to fail. And once it begins to fail, it's a downhill decline, resulting in death. Fortunately, there is liver transplantation, but transplantation, of course, is costly, and it's just not available everywhere. But in the United States, it's a common single indication or cause for having liver transplant. This disease is just unbelievable. Because of the latency, that in fact here we are in 2011, we are at the peak and ever infected and chronic carriers, but we're still not at the peak of, and we're certainly not at the peak of hepatocellular carcinoma. So the burden of hep C in the States and worldwide, the serious burden is really yet to come. We look specifically at transplantation, hepatocellular carcinoma. Again, these burdens are yet to come. An incredible societal impact, whether it's in a country that follows and monitors resources to deal with it or not. So the commercial impact is estimated to be about $85 billion per year. And so this is one of the most serious illnesses that we deal with. And so lots and lots of research. And the first thing that was thrown at it was to put an end to new infections. New infections prior to cloning identification were about 350,000 per year. It's about 35,000 per year. Instead of being from blood transfusions, it's extremely to have a blood transfusion because we screen both with serological, and then what the advanced molecular testing offers is, because of their activity, the RNA from a chronic or an acute infection from a tainted picked up about 50 days earlier than the serological test can. So in the United States, Europe, and many countries are screened not only with the serological test. Now, I alluded to cost effectiveness of clinical algorithms. The cost of the unit by adding the molecular test is about $250,000. Yet, because it can be fatal, it's become standard of care. Now, the tests that are performed are dependent on the genome, and the genome that uses a polymerase with no proofreading function, and there are lots and lots of mistakes and lots of variability in the hepatitis C genome. The region is constrained by selection to be least variable is this 5' untranslated region. And this is the region most conserved where the qualitative and quantitative assays are focused. A second type of testing, very important for modern algorithms, is the ability to say exactly what type of hepatitis C, because there are indeed types 1 through 6 that you can be infected with. And so we're transitioning from tests that attempt to do genotyping in this very conserved region, especially with the newest drugs, that the accuracy of this genotyping is not great enough to be conserved. It's not enough genetic variability to completely separate out the types. So interrogation can be done in the core region or NS5B. The problem is that these regions are so variable that it becomes all of the cases to design primers and probes. Other things about the biology of hep C is that unlike HIV, which does not integrate into the DNA, beyond the spontaneous cures, if we're able to bring a hair on it, which reduces the titer for an extended enough period of time, this disease can be completely cured by therapy. So here's the genotypes in the United States. Unfortunately, the most aggressive genotype, the type 1As and 1 most common. In Asia, actually, population is lucky. The most benign types, 3 account for about 50% of isolates. Using the core region and the NS5B region, recently people have identified a very, very elaborate and accurate subtyping. So within types 1 through 7, we know that there are subtypes. So I just mentioned are types that have the best outcomes and are most. If we look at the difficult type 1s, if we look at type 1A, more aggressive type of hepatitis C than a type 1B. And I'll show you a story of, with the latest protease inhibitor drugs, that the ability to spawn resistance is also different based on subtyping. People in this field believe that subtyping is very, very likely to be correlated in how we use the next generation of drugs that are coming out in the next 3 to 5 years. So molecular quantitative testing, molecular genotype testing, actually fairly simple to create, very analogous to assays that you do in your research, are what is called for and is what has made a tremendous impact on clinical. So how has this been done? What's the example of this? Well, we have to go to treatment. Back to the example. So the standard treatment now, or at least until 3 months ago, was a form of interferon pegylated so that it has a longer lifespan in the blood. And pegylated iron, which inhibits the polymerase, given for a defined period of time. Care. Type 2s and 3s are treated for a shorter period of time. The worst outcome are treated with a longer period of time. So genotype information very early on created this very simple, very, very simple, but very, very important how patients are treated. The problems with the treatment and the reason why patients are identified here, this is an underestimation. It's probably 20 to treat patients. There are bone marrow toxicities, and in fact, being on interferon or a year can be so difficult that patients are pre-screened with a psychiatric to make sure that they're going to be stable and are going to be able to tolerate the inconveniences and the discomforts of therapy. So there's a tremendous to decide when we treat long and when we treat short, and as a parenthesis, a tremendous drugs beyond interferon. Now this is a very, very old slide, but I think it illustrates very nicely the difference between the type 1 and the type 2-3 outcomes, whether it's an early therapy or the most advanced therapy shown in yellow. For type 2 and 3, to completely cure about 76% of patients who walk in the door. For type 1, the most common one in America, the success rates are less than, and then it's true for all of the other therapies that have been looked at. Genotype-driven therapy has been standard of care for about 7 or 8 years wide. Type 2s and 3s are treated for a half a year. Everything else for 1 year. And this alone, as simple and as obvious, has a fantastic impact on patient care, patient well-being, therapy. Now, a patient who comes to diagnosis and is treated will show a decrease in the viral titers in the plasma or in the viral load. That is not always the case. We have fewer than 50% who respond to type 1. So these null responders can be identified by, again, a simple quantitative viral load assay. leading to the second really important algorithm. And that algorithm is a stopping algorithm. It is now understood that if you increase your viral load by 100-fold or 2 logs by week 12, less than a 0.5% chance of ever responding to PEG interferon ribavirin. So imagine of patients who initiate therapy and 5% of them who are never going to get better on that therapy, rather than being treated for a year, they are now parsed out and separated at week 12 into patients who stop therapy at that point, the new drugs to come, versus patients who have fallen and will at the end of 1 year. Again, very simple, seemingly obvious, but just in terms of its impact in medical care. Now, just pause and say, technology. You're going to hear all about technology during the next presentation, and time PCR is probably familiar to lots of you. The point I'd like to make is that the technology of FDA-approved assays for viral load determination, assays for genotyping, are basic, fairly simple to do assays. The second point would be that we are in need of assays that go beyond them. We're in need, in the same way, HIV assays that can do simple viral load testing with portable monitors out in the field. We need of the same kinds of next-generation technologies. So the physicists in the room their sleeves and deliver some technologies that go beyond these FDA-approved tests. We're doing very, very simple methods, and again, these need to be approved as well. And importantly, they need to be achieved in a much, much cheaper format than they're available. Okay, so we've talked about 2 important algorithms that come out of very, very simple, generalizable tests. The third one that I would mention is the notion of kinetic, first done for the hepatitis B virus. Hepatitis C virus kinetics, when we look at I versus cells that are lysed and their virus reinfects, it was realized that there were different phases of decline. And clinically, the message is that there are patients who will have a rapid viral response, patients that will have a viral response, and patients that will have a delayed viral response. And genotype and trumping the prognostic value of genotyping, viral genotype, the likelihood of having a sustained viral response and being cured forever is proportional to how early you respond. So if you respond by 4 weeks, which is the definition of a rapid viral response, instead of having a 47% chance of being cured of a type 1 infection, you have something more like a 90% cured. So that has become the third standard of care algorithm by very, very simple assays. And this is from the 2009 AASLD guidelines. I won't go through the definitions here, but we'll point out that what is done now, because of this information, patients with rapid viral response who can not only have that they have a high probability of being cured, but in fact they can be treated with these drugs, these tough drugs, for much, much shorter periods of time and have the same likelihood of having a good outcome. On the other hand, if we look at patients that have an early viral response, these individuals are now standardly treated for longer periods of time, and this in improved outcomes and rates of sustained viral response. Okay, so there's like 4 really important algorithms that come out of tests. Let's talk about tests, molecular DNA, and the next generation of drugs that are coming. This slide, but it identifies within the lifestyle of replication of hepatitis C, where after uncoding the viral RNA and binding from a translated region, there is translation into a long propeptide, which is then cleaved protease and then cleaved further by a viral protease. So an area to intervene with new drugs is to develop protease inhibitors, and we have for HIV. Another region is to target drugs that, additional drugs that interact with the polymerase. And so we now have in clinical trials nucleoside and nucleoside inhibitors that will be out during the next 3 to 5 years. This is out of the last European meeting, summarized 2001 drugs, 2011 drugs, which is ribavirin interferon. We have in the pipeline, and we expect to have out in the next 7 to 8 years, more like different drugs. So the usual problem of not getting drugs through the FDA is not going to be the case here. The problem that will continue is the problem that these drugs are going to be not interferon, but they will cost half the price of interferon and will have to be used in interferon. So 2 of them were approved and released and are rapidly into clinical use just this last year. The protease inhibitors telaprevir I'll show you their efficacies in a moment. They are associated with side effects, same as any other drug, I guess. But one now for somebody who has side effects to one drug of switching them to another drug, and hopefully they won't have side effects. How much more effective is doing a triple therapy as interferon, ribavirin, and a protease inhibitor? Well, it's dramatic. A patient who's never been treated, here's the patient naive, and by the way, these drugs are developed specifically for type 1 virus, the most difficult to treat. So they were knowing the structure of the protease and doing molecular to develop small molecules that would inhibit the protease. So from 44% up to 75%, which is colossal. Patients who are treatment experienced and have failed treatment, if you try to do that, you have a 20% success rate and you have a 66% success rate with the new treatment. So this is just a fantastic improvement in pharmacology. So molecular testing. Does molecular testing continue to contribute in the arena now of having 3 expensive drugs that the patient decide whether to treat, take early, take for long periods of time, take for short periods of time? The stories are just emerging, but they're interesting. The first is, akin to HIV, is the patient becoming resistant to a protease inhibitor. Who were treated with first-generation monotherapy for HIV, and it was anticipated that this would happen in the case of inhibitors, so intentionally they were not used until they could be approved and triple therapy with ribavirin and interferon. It is still that most patients during a successful therapy will see emergence. So it's unclear how important this algorithm of testing will be. Existing viral genotypes that can be described by the simple assay I've already spoken actually reveal some subtype-specific resistant patterns. And so here's an example. It turns out, as we look at the difference between a type 1A, the more difficult virus, and 1B, that protease mutation, this RK mutation, does not emerge at appreciable frequencies in genotype 1Bs because of on usage in the virus, 1A versus 1B, because it requires 2 mutations for you to become resistant if you're a type 1B virus. On the other hand, 1A virus, the emergent resistant rates are much, much higher. So this may become another guiding principle, or at least a prognostic principle, in the likelihood of response to protease inhibitors, especially for the difficult to treat patients. Second is in the setting of these nucleotide drugs, and I won't go through except for to say that the nucleosides really hold great promise because they have very, very high barriers to resistance. But nucleoside drug HCV 796 has been shown in both type 1A and type 1B viruses to give rise to this mutation, very high level resistance for both of these genotypes. However, when it arises out of a genotype 1A, that virus is crippled. It has only 10% of the wild type replication fitness. So again, customized medicine information using triple therapy for life responding. All of this information in the case of genotyping, the approved test, this is simply an outline of going beyond 5 testing, simple assays that have been described in a couple of laboratories. This is our version of it, where straight PCR and doing Sanger sequencing allows tests that can interrogate most samples and very, very accurately make these distinctions. Let me finish with one final assay very quickly that has happened during the last 2 years that doesn't involve viral genotyping at all. It's an example for Hep C where there's a salient discovery of human genotype, a prediction of likelihood to respond in patient management. So by the time genome-wide associations in patients who responded or did not respond well to therapy or spontaneously or did not spontaneously get well, it was discovered that in fact there are polymorphisms associated with a different type of interferon, quote, lambda interferon, which is for responding to a number of viral infections. On chromosome number, its association with how actively lambda interferons are produced or not in progress. But simply by looking at one of 7 different SNPs that have been in this region, one can categorize patients into most favorable zygote genotype CC, next most favorable CT heterozygote, or least of outcome TT genotypes. These genotypes have different internationally. So I mentioned that in Asia, hepatitis C, good news, a lot of it's type 2 and type 3 virus. Good news is that a very, very high percentage of CC human patients that are more likely to spontaneously get better or to respond to therapy. And this data just simply shows it for European, African American, most difficult to treat populations, Hispanics, and then a combination, both for response to therapy and therapy. The take-home message would be that the differences are not subtle. They're dramatic, either in response to therapy or spontaneously. And so in the last 12 months, hepatologists in Europe and the United States have rushed to bring online to give this information to physicians and patients in terms of their likelihood of response. It applies to all of the different genotypes. The CC genotype helps you get better from all of the types. And so I will just finish with sort of some molecular contribution. Going back a little to the discovery of hepatitis C, it was quickly realized that the amount of virus, when it was high, was a bad predictor. If you were male, it was bad. If you were older, if you were African American, it was worse. If you were heavy, it was worse. If you had fibrosis of the liver, if you had metabolic syndrome and fatty liver, it was worse. If you were insulin resistant, it was worse. Much, much worse if you continued to drink when you had this infection, even just with beer. All of these predictors are trumped by 28 human genetic information. But I would add to that during treatment, whether you respond early in the kinetic model, RVR or not trumps everything above it. So we've gone as a benefiting from molecular technology discovery through all of these generations of algorithms down to sequence therapy and host-guided genetics, awaiting a new line of drugs that in clinical trials so far suggests that going from cure rates with the first generation interferon of maybe 20%, curing 85, 90, or 95% of patients, and do it without interferon. And so I will close with that, and just at least acknowledge people in our laboratory who have worked on the development of tests, Melanie Mallory, who have worked out our high-resolution genotyping assays. And I'd be happy to take any questions.
Questions from, there's one question over there, Dr. Padilla.
Really? So type 1s are more common than 2s and 3s in the That's interesting. If you go to Taiwan, not far away, and look at the viruses, it's at least 50% 2-3s.
Another question over there.
My question is your experience on the development of molecular diagnostics for the practice of doing these tests. A lot of our lab here in the Philippines, like we have generated some homegrown PCR-based techniques to diagnose some infectious diseases, and so like some have developed like a diagnostic test for amoebiasis, for example, or like our lab have done some like diagnostics for. And then we have come up with some sort of like an algorithm, like a series of that more or less this could like somehow help already the clinician. Now, my question is like, what was your experience in like making the clinician appreciate the algorithms of these like different events, such that they can integrate them in their practice?
That's an excellent question. Communicating when to use molecular tests and how to integrate it into algorithms. And I would say that one of the things is to overcome a superstition that the molecular test is always correct. There's never false positives or contamination, or that the molecular test is always a test to order. So West Nile virus, for instance, when you're infected at day 0 and 7 days later you present to the physician, you no longer have any West Nile virus RNA because the IgG has taken titers down to undetectable levels. So you don't use the molecular fancy test. You use a serological IgM assay. And the list goes on and on and on about how to use tests properly. It's really difficult. What I think the best hope, I would say two things. One is to put online, as you order tests, a console description that simply summarizes how to use a test and speaks to its strengths and weaknesses. So as the test is being ordered, they can read this one-page simple diagram that simplifies, because you're not going to be able to be on the phone and talk to all of those physicians. The second is that when you report out a result, rather than just sending the result, if to the extent that you can have a footnote that always goes with the result, so that when the physician is going to look at the result, which they're very motivated to do, they have to do that, they will have below them a simplified description of the strengths and weaknesses of the assays. Then they read into that, perhaps they will not just knee-jerk and do something or the other, and maybe it'll be a motivation to call their pathologist or clinician and dialogue with you about the subtleties of the testing.
Okay, I think we'll, thanks Dave.